Bob already gave the first part of my talk. And Denise, thank you. You're a very tough act to follow. But Bob forgot to tell you that we're supporting that trial in Europe. Ah, see. So this is darker than the usual room we work in. And I also like to hear from you. You know, ask those questions that are unanswerable, so you can stimulate us to be thinking. So they told me I only had 2 hours. Not true? I'd like to take you through probably more quickly than you can digest it. We won't give you a test. I want to touch on what I think are some of the highlights, but the theme has already been represented. The theme is that if we're going to cure something, we need a lot of people to work together to do that. And I'll come back to the theme of collaboration and partnerships. And I had the privilege to be here this morning to see the labs, the hospital, the research institute, meet with the researchers. It's been a real delight. And you know, I'm just so pleased and appreciative that you actually invited me to join you for a short time to do this. The other thing that you're probably not aware of is this is the 40th anniversary year of the founding of JDRF and the 60th anniversary of the founding of the National Institute of Diabetes and Digestive and Kidney Disorders. We're not celebrating because we haven't actually finished the task, but we do need to mark the moment. The important point about JDRF is that it's driven by parents, and that relates to the scientific and lay review that we have that's quite unique. Lately, our funding has gone down a little bit. We're working hard to support to get that up again. But we spend about 35% of our research budget outside the United States. That's very unusual for U.S.-based foundations. And the logic is that our parents of children want to support the very best research that could be accomplished to get the job done, wherever it's located. And as I go through here, you'll see some of the things. And Bob just gave you a good example, the Thomas Mander-Polson trial in Europe that's working on the substance that Marty is and we're going to hold you to that, Marty. Everything that Bob said is just a terrific example of scientists working together, and the borders are becoming shorter and shorter, smaller and smaller. A kind of a grim reminder, it is no fun having this disease, and in the past 30 years, a lot has occurred that's changed at least the life and the lifespan of people with type 1 diabetes. So doing a variety of things on the way to finding a cure is really important. I don't want to go, this is not the time to go through in minute detail, but many things have occurred. The long-term survival, the lifespan, it's not quite perfectly normal, but it's really heading there. And there are collections of patients who've had type 1 diabetes for more than 50 years. The medalists that are collected at Joslin, there's more than 500 or 600 people who are actually doing fine with no complications. And we're studying them to find out what's special about them that they're able to do fine after 50 years with no complications. Insulin, improvements in insulin come a long way. Go back. We can monitor blood sugar. The hemoglobin A1C program has enabled. There's been many incremental benefits. Now, nothing has been as incremental as the tight control of diabetes. The DCCT trial started in the 90s, that still continues to be followed, was the first to demonstrate that an exquisitely tight control of diabetes really made a change. And These numbers are intended to reflect the decreased frequency of eye disease, kidney disease, nerve disease, and cardiovascular disease as a consequence of implementing tight control. And unfortunately, not every citizen gets it, although in your community apparently lots do. This is a table. You don't have to try to read it, just to confirm the changes in long-term life. Denise, you must have known I was going to show this slide, and you're right. It's horrible. So here in an 8-year-old, how many finger sticks? 20,000, 8,000 injections. This is not a fun disease to have, and it's 24/7. Something I think that's a bit surprising is occurring, although on the front lines it's probably not so surprising, that the incidence of this disease is actually increasing in the modern era, particularly in the Scandinavian countries, but also in the States, and younger kids are getting it. I do want to correct one impression. Probably 50 or 60% of the cases do have their initial onset in type 1 diabetes in the age group around 10, 12, 13. But 40 or 50% have them when they're 20 and 30. And that's kind of an understudied event, really what I would say is adults with type 1 diabetes. And every time we think about those kind of statistics, we realize how very complicated this disease really is. Now, the fact that it's increasing like this means for practical purposes that the genetics in and of themselves can't be responsible. And that stimulated people to think about what is it in the environment that's triggering this autoimmune process. This chart I do want you to memorize. On the left side, this is a cartoon to tell you about the entire disease from birth to long term in relation to the functional beta cell capacity. Now, type 1 diabetes is a disease that is lacking insulin secretion. Insulin is secreted by beta cells and islets. And if you're unlucky enough to have the disease, presumably you have a genetic susceptibility, an inciting event comes along, you start to lose beta cell function. But for a long time and a period of time that we're not actually aware of, could be several years, could be 5 or 10 years, it's quite silent because you haven't lost enough insulin secretion function to have actual diabetes. When you lose about 90% of your beta cells or so, you have the clinical onset of diabetes. And then if you don't do anything about it, the beta cells disappear and along come complications. And insulin doesn't cure this disease because it restores beta cell function, but it doesn't fix the autoimmune response. It doesn't change the inflammatory issues. So there are a whole lot of things that we need to fix at the same time. Now, what this cartoon does is gives us a chance to ask the question, where could we do research so we could treat and intervene and change the dynamics? So if we could stop the immune system from attacking beta cells, block autoimmunity so these beta cells wouldn't get lost, if we could protect them in a variety of ways, maintain normal blood sugars in spite of the loss, and at the end, a combination of restoring beta cell function, blocking the autoimmune response or making it go away, inducing tolerance, maintaining high-quality regulation of blood sugar. While we're waiting for all these things to kick in, we should be able to prevent and avoid a significant amount of complications. Now, the nice part of the discussion today is some of these things have actually occurred. Now, I do want to take a moment to have a commercial announcement. JDRF has been lobbying for a decade. The children with type 1 diabetes have been lobbying for a decade, the U.S. government. And that government has provided, over the past decade, over $1 billion in earmarked special funds in addition to the regular NIH funding. That's helped in major ways putting type 1 research on the map, because in good or bad times, investigators and young people like to go where the money is. And that's been very important. We're in the process of trying to renew this for another 3 years. And of course, to accomplish that, we send the children to visit their congressmen and senators and ask them for money. Now, I want to highlight some of the studies that have been supported by the Special Diabetes Program in conjunction with the platform of NIH spending. You may be aware that our public health service in the United States is not quite up to snuff in relation to Finland or Sweden. If you have this disease in Finland or Sweden, you go on a registry and the government knows that you have the disease. They follow you forever. You get early treatments, no question. You always get a referral, et cetera, et cetera, et cetera. None of that happens here, and we don't even have any good statistics. And one of the major studies is called the SEARCH study, which in all these sites, essentially what people have done is gone into the community and tried to identify all the cases of diabetes in people 20 years old or younger, type 1 and type 2. And that's begun to put a face on what's happening and actually confirm this increasing numbers, so that we can go to a state and governmental federal agency and actually sort of beg for something to be done about it. If there were an epidemic like there was of H1N1 or something like that, an infectious disease, everybody would be jumping all over it, because we don't have a viral agent to follow. We don't bother getting very good statistics on chronic diseases in the United States. Genetics, which is one of your strengths in research here, has actually plunged ahead in type 1, way ahead of some other diseases, and partly because people throughout the world have volunteered together to provide blood samples and information about their disease. And the goal here is I understand that Francis Collins, who inaugurated the lecture series, so I'm very pleased about that, told you about personalized medicine and pharmacogenomics, which we don't have time to go into today. But what's not understood is the investment in getting enough samples from enough varied people so that we can then share them with researchers and do the studies that identify today in type 1 more than 40 genetic regions. Takes time. That's been a decade in coming. But now, making that information accessible and the data accessible and the samples accessible, we hope to shrink the time when we discover what are the important regions and what do they have to do with biologic function and change outcome. And what Bob was describing from the work here, if we had a molecular signature that somebody was going to get type 1 diabetes and we knew the immune pathway that was affected, we already have some treatments that actually might block that. We just don't know who to give them to. So if we can work that out, wouldn't that be wonderful? So the timing is spectacular to see real meaningful progress in type 1 research. And at the same time, type 1 is kind of the signature disease for all of autoimmunity. It's the one where we can study the disease very early. Most of the people who work in autoimmune disease, let's say the rheumatologists who study rheumatoid arthritis, lupus erythematosus, most of their studies are done in end stages after people have had disease for a long time. They're trying therapies in very late stages. What we learn from type 1 studies presumably will be applicable to those diseases, and that's very important. Now, I mentioned to you that people are very much interested in the environment, whether that's a virus, food, self-autoantigen, something that triggers in those genetically susceptible people why they're getting this disease. And TEDI is the environmental determination of diabetes in the youth. This was supported by the Special Diabetes Program, And when I say it wouldn't have occurred without that, it's about a $25 or $30 million a year effort worldwide. And the regular NIH budget typically would go to fund individuals for research grants. And this special funding let them put clinical consortia together that actually provide the materials to do the study. Now, this study follows actually children from birth, measures, I don't know exactly how often, but no less than once a year forever. And it's now running in about year 7 or 8, and there's starting to become some cases of type 1. And these would be the source of some samples that could come back to the McGee Center for seeing if that molecular signature is going to identify prior to any other measure who those kids were. A study that you couldn't do if we said we're going to do that study today, but it's going to take us 5 or 7 years to first collect some samples, etc. Preserving this is a very, very important event. I like to remind people that if we lumped all the autoimmune diseases together and said they're very important, they collectively would come in number 3 right after heart disease and cancer, the people who suffer from autoimmunity. And there are many more common features than there are differences. So knowledge and therapies in one autoimmune disease can be informative in others. And that's what genetics is telling us, not only in type 1 diabetes, but in autoimmune diseases. And common pathways are the message of how to do that. Celiac, unfortunately, is one of those autoimmune diseases that is occurring fairly frequently in type 1, as often as 8 or 10%. But other multiple autoimmune diseases occur as well. Now, interestingly, the study in Europe that's testing an immune modulator, an anti-inflammatory, was developed not for type 1 diabetes, but for rheumatoid arthritis. And that's when the early studies were done. So taking it and moving it over and testing it in type 1 is logical. And the advances that already occurred saved time in starting up the study. We've had some, I would call, pretty spectacular successes in this area. And the treatment of individuals, you remember the curve that you memorized? So before all those beta cells disappeared, like just before, you're in a mode where you could maybe prevent what was happening if you knew that, or as soon as the disease starts, you're still having some beta cells left. So if I have a treatment that I could administer within 4 weeks or 5 weeks of the time you have the clinical onset, that's what we mean by new onset, and that blocked the autoimmune response, the curve would stop going down and it would flatten out. And a monoclonal antibody called anti-CD3 and an approved drug, rituximab, another antibody to block a B cell, and something called GAD, which you'll hear about, all have the common feature of if you treat people just at the time of diagnosis, you can preserve beta cell function. In the original anti-CD3 studies that we supported actually on both sides of the ocean, the effect is now at 5 years in one study from Europe and 4 years in the other study from the United States. Now, let me repeat that. Here's an antibody that blocks a particular immune response, an autoimmune response, and stops progressive damage to beta cells. The treatment is 7 days, and in one case 10 days, 4 or 5 weeks after the onset of the disease. With no further treatment, 4 and 5 years later, you still have beta cells in 70% of those people treated. And the more successful 70% were characterized by starting with more beta cells than their colleagues who didn't do as well. Now, to me, that's a remarkable piece of information, and it gives you hope that you could do a whole bunch of things. Now, those two drug companies are involved in the creation of anti-CD3. That will come on market probably in 3 or 4 years. It's not perfect. It has some side effects. But if I told you that your child who just got the disease gets treated for 7 days, and 70% of the time the beta cells are going to hang in there for another 5 years, you'd probably think that's a useful thing to do. And the idea now is to expand the research. Do we have to give it 4 or 5 weeks after onset? Could it benefit people who've had the disease for a year or two, depending on how much beta cell function they have? Or what I think is more interesting, why wait till you have the clinical disease? If we could identify the people who are at great risk and treat them before they have the clinical onset, maybe we could actually prevent the disease. Now, I've just described probably 5 or 10 years worth of clinical studies at multi-millions of dollars. But that's a very promising road, and we're working with some of the consortium groups to do exactly that. And it's a shame that it's not going to come next week, but the potential for progress is just simply enormous. This is to remind you, to tell you a little bit about where we are with beta cell biology. Obviously, the insulin secreting cell, the one that disappears from type 1 and makes you have to take insulin, if we could restore that, that would be great. And this conversation about how to create a beta cell got to be very lively in the stem cell debate that began in the late 1990s, because proponents of stem cell research said something that sounded too good to be true, which was if we had embryonic stem cells, we could start over here and instruct them to make all those pathways that lead the pancreas to make beta cells. And wouldn't that be magical? We've gotten about this far consistently to the pancreatic progenitor stage. This slide hedges that it says beta-like because these cells that have been produced and reported to date are imperfect and not ready for prime time. So the science has come along in amazing ways. But one of the things that was forgotten in the dialogue was that if I gave you some beta cells and didn't do anything to stop the autoimmune response, guess what? Those beta cells are just going to die and you'll be back where you started. So that's just to remind you that we're not going to get a silver bullet for this disease where if you do this one thing, it's going to fix everything. And we need a combination approach. So we need to make the autoimmune response disappear. Now, on the last slide, I showed you that anti-CD3 has the possibility to do that, but that's a kind of a broad-based approach, and we want to refine that approach a little bit. But some combination of blocking the autoantibody response and then restoring beta cells would do wonders. This is creating a fresh supply of beta cells. Islet transplantation studies don't create a fresh supply. They take the cadaveric donor pancreas, purify islets from them, isolate the islets, infuse them in the portal vein into the liver, and in a relatively handful of people who have the clinical problem of hypoglycemia, unawareness, disabling disease, very difficult to control, they get enough restoration of insulin secretory function and C-peptide production that actually doesn't cure it. And you have to take immunosuppressives because it's a transplantation. But if you're one of those few, it really is a marvelous thing. What islet transplantation has shown us is not so much that this is going to be the pathway to a cure for lots of people. What it's shown us is that in real human beings, you can restore beta cell function even though it's for a limited time. The limited time these days is about 3 to 5 years. You do have to go back on insulin. However, in many of those patients, even going back on insulin, the hypoglycemia unawareness has reversed, and a couple of the complications, eye disease has improved and nerve disease has improved. And there are very few therapies for those complications today. So we consider this a kind of proof of concept that restoring beta cell function could be really good for you. And even if it's only a little bit, it can have an important biologic consequence. Hypoglycemia, every parent hates that. That's why they don't sleep at night. I didn't bring you the cure for this. I would say the major advance in hypoglycemia is in the management, and the continuous glucose monitor story is improving that each day. And we supported this study that was published 1.5 years ago, which said, if we use continuous glucose monitoring, can we improve the quality of control? And the answer was yes. The great answer was yes in an older population, 20, 25 and older, because the compliance rate for usage was excellent in that group. When teenagers, adolescents, and children used the device, they also improved. But there were too many of them who didn't like the device and didn't use it so much to be statistically significant. However, it did reduce the number of episodes of hypoglycemia, and this continuous glucose monitoring fit into our JDRF goal of high quality control of blood sugar. And we said, what can we do to advance the science of an artificial pancreas, or setting up a situation where you have a glucose monitor, in the middle you have a computer algorithm and an insulin pump, and could you close that and put it on somebody and automatically monitor and deliver insulin, thus closing the loop. Now, it's not really quite an artificial pancreas. It's a little complicated, but we said, how can we take that forward? So one thing we needed to do early on is, if you're wearing a pump and you get a low blood sugar and the monitor says it's low, why not turn off the pump? That's already occurred. You could minimize the excursions of hyper and hypoglycemia. You could work your way around to even automating the system. And I think I have a picture. No, I don't have a picture. Here's a situation where the manufacturers, the industry produces the technology, but the FDA doesn't like industry-sponsored studies as much as it likes independently sponsored studies. So JDRF took it upon themselves to fund it and to fund the work towards closing the loop. And those researchers are working actually on both sides of the Atlantic. There's a collaborative group in Europe funded by the European Union. There's our own collaborative group. And this is where they're taking current technology. It's a bit complicated, but what's amazing is that the algorithm people now have stuff to prevent hypoglycemia at night. They have algorithms for exercise, for ambulatory kids, and now it's just a question of doing enough clinical trials to prove efficacy. And of course, at the same time, we need the manufacturers to miniaturize and enhance the technology so you're not wearing too many things. I do want to say one other thing. The whole business of continuous glucose monitors and implementing this in order to achieve tight control so we can reduce complications, roughly speaking, says we'd like to take really excellent care of you while we're working towards a cure, because we need people to be in good shape to take advantage of these other therapies. In the process of doing that, JDRF has expanded its agenda beyond only funding research for a cure and funding work that goes into the issue of how to implement, how to teach, how to educate, and we're slowly doing more and more of that. Now, there is a spectacular success in one complication, that of eye disease. And I don't know why this manages not to say the name of the drug. The reason you get eye disease is in part related to proliferative growth of blood vessels. So Genentech was sitting on a cancer drug that was anti-vascular endothelial growth factor and blocked the formation of blood vessels. Now, for those of you who study and follow this disease, you realize that the complications of diabetes are heavily related to the vascular changes. So in the eye, if you have overgrowth of blood vessels, that's not good for you. But in the heart and the kidneys, you get too few blood vessels. So if I have a drug to block the growth of blood vessels in the eye, I don't want to block the growth of blood vessels in the heart or the kidneys at the same time. So I have to figure out a way to administer it locally. So researchers said, well, that might work in the eye, but we have to give it locally. So in studies done in diabetic macular edema, this drug, the anti-VEGF, it's called Lucentis, blocks the growth of the blood vessels and reverses that disease. Now, we have laser treatment for diabetic proliferative retinopathy, but laser stops further progression and leaves scar tissue. It doesn't actually reverse things. So halting progression is good, reversing is better. And Avastin, the parent of this drug, is actually therapy for some forms of cancer, where the effect of cutting off the blood supply actually improves the cancer. It starves the cancer, and it's a cross-fertilization of science. Now, how to get the job done in a very complicated world? We figured early on we couldn't do it alone, and we needed everybody to work together. And we work with all the National Institutes of Health. We work actually with the Department of Defense. We had involved NASA in some earlier studies. The CDC helps to fund that search study that defines the incidence and frequency of type 1. And as I had said, unusual among foundations, we work outside the United States. This is actually a constantly changing list. But I put it up because I think it's important and actually quite relevant. And you had an example that the work that says you can have an early signature to diagnose type 1, and coupled with data coming from a study done in Europe, and if we work together we'll get there quicker, suggested to us early on. The reason we started all these partnerships, we put up some of our money and said to other governments, it's better if we work together. Type 1 diabetes is important in your world. And people bought that. And this has flourished to the extent that the European Union, which you don't probably pay a special lot of attention to other than the euro-dollar rate and Greece floundering. But the European Union collects a lot of money from all the European countries and then gives it back to researchers. It's one of the largest sources of research funding in Europe, in the multi-billion-dollar range. And we're proud of the fact that in their recent rendition, they have an increasing number of projects dedicated to diabetes, type 2 and type 1, but with a real portfolio in type 1. And because of that, we're actually in the process of launching a clinical trial network in Europe, a JDRF clinical trial network in Europe among 12 countries to take advantage of their healthcare system, doing clinical trials quicker, smoother. They have registries of patients. And our whole notion is we want to get the job done. We may not be able to predict which treatment is going to work from animal experiments, but what we know is to find out the answer to that, you have to do a proof of concept clinical trial to get the job done. Doing that in the United States is fairly difficult these days. It's enormously expensive and getting worse. Doing it in Europe is economical and very collaborative. So we want to do what we have to get the job done. This slide is also to convince you there's another area of all foundations have recently discovered that industry has the potential to be a good partner. What people haven't talked a lot about is that we can fund all the basic research and the proof of concept studies, but basic researchers, clinical trialists, proof of concept studies are not the way things get to market. You need industry to do that, and you need to involve them early and get them interested in the topic. And the studies in eye disease with Genentech were done with JDRF help and Johns Hopkins and a few others. And as you would predict, as that work has gone on, we have an increasing relationship with that company. Lilly and Glaxo took over from the biotech companies that were supporting the anti-CD3 work. And over the next 5 years, we anticipate an increasing list of these kind of partnerships. So I wanted to at least introduce the topic. And I want to close with, we have something called Clinical Trials Connection. If you go to our website, fill in information about yourself as a type 1 patient, and this will come up with a kind of a matching service that tells you at a glance what kinds of clinical trials might be of interest to you. This is the beginning of a process that we'd like to engage in to help patient recruitment, which is a major obstacle for most clinical trials. This is the NIDDK website, which has similar information. It's a little more complicated. And I want to close with a commercial message. Some of you, hopefully many of you, will be getting requests from our local chapters asking you to help fundraise in Washington to continue the money for NIH for the special funding. So at a minimum, I hope I've convinced you that that's a good way to exert time and energy. We have a coalition. There's a Diabetes Caucus in Washington, about 60 or 70 senators and about 300 or high 300s of congressmen have signed on to a Diabetes Caucus, which says it doesn't come with a checkbook. But what it says is that I, as a congressman or senator, support the effort to do this. And it gives you an ability to walk back in on another day and say, here's some good things we've been doing. Help us continue to do that. Help us help our loved ones. And of course, I don't ask for that, but some of the kids and their families ask for it. It's a very powerful message. Nobody stopped me to ask questions. Nobody shouted. So let me quit on a high note. And I think we have time for questions, or if not, okay. Thank you very much.
Comments or questions? Yes.
Yeah, so that's the discussion about autoimmune diseases. And anakinra, the blocker of the inflammatory response, is approved for use in arthritis. And that's being used in a trial in type 1. There will be an increasing number of those. You have to pick and choose, though. The good part is that it's easier to use an already approved drug and get it through the FDA because you have a lot more knowledge base. The bad news is that many of those drugs have been used for something that doesn't fit the chart of what you'd like to do. Or worse, what most of us think, it will take a combination of drugs. We don't have enough combinations yet to test them all, but that's called repositioning, what you just described. People are very interested in doing that to save time and energy. Well, it's off-label. I mean, you have to go through and get an IND and all that kind of stuff.
Other questions? Julia?
Are there any clues about what the environmental impact might be that's contributing to the virus?
Yeah. So there's a clue a week. Did everybody hear? The strongest data comes from Finland. And the Finns believe that enteroviral infection, which is a ubiquitous agent in children, that in some children who have the genetic predisposition that actually acts as a trigger. And what they're trying to do to prove that is to study samples from people who have been studied from birth on, and they have a lot of those in Finland. In Australia, they think that that's rotavirus. Around Pittsburgh, they think that's cytomegalovirus. And what you'll read in the papers occasionally is there's a kind of an epidemic in my neighborhood of 6 or 7 cases. Cluster, it's called. And so people go and try to sort that out and never come up with the exact answer. So we're not there yet. Also, there's probably enough cases that, don't need an external inciting agent. It could be a misrepresentation of an immune response within you. So it's a complex issue. It's very interesting. The sister or brother to that discussion is something called the hygiene hypothesis, that one of the theoretical explanations for the increasing frequency is that as modern society has become cleaner, the kids don't eat dirt. They're young as much, and their immune system is not exposed to all this other stuff. They don't get a whole bunch of protection to this other stuff, whatever it might be, and therefore they have a higher frequency of allergic diseases, asthma, type 1 because of that. And there are models for that. So, for example, in Finland, where as many as 55 and 100,000 get the disease. Estonia, which is a small boat ride away from Finland, where the kids were brought up with lousy hygiene, their numbers are like they are here. So, big contrast. That's the kind of closest information that speaks to an environmental agent. Sorting that out is really challenging. So regular childhood immunizations have all been studied. There's no association whatsoever. And no matter what any scientist reports or says, it's a recurring question. So it would be great if I could tell you that vaccine X gives you type 1, because we could then stop it. It just doesn't do it, and there's no hint from any of the data. Bob should comment on that.
Well, actually, vaccines probably help, because rubella, in general, rubella infection with the live rubella virus has been known to be associated with diabetes, whereas the rubella vaccine prevents that and is not associated with diabetes. So, we have to look at the hard data and compare what was present before the vaccines and after. But to date, there's no association with any of the vaccines that are commonly used for children with diabetes. And quite frankly, many other things. We're looking into that. But maybe next year. David.
There's some evidence, I don't know really how good it is, that some parasitic infections can down-modulate the immune system, sort of co-evolution.
Interesting.
Any ideas?
Hasn't been done in type 1. And if you think about it, the places that have the endemic parasites don't have a lot of type 1. So it's probably not known. Be an interesting study if you could sort out how to do it.
So eat a little dirt and John's joking.
Well, the dirt hypothesis is pretty solid for
Other questions? Thank you, Bob.
Oh,
Did
go
you
ahead.
have a question? No?
I'm just curious about, I did memorize that chart. What do you recommend for siblings of type 1?
That's a good question. So I recommend that you join one of the studies that are looking, because they periodically test, and with current state of the art, not with the future state of the art, we can't actually tell you for sure who's going to get the disease. We can pretty much follow you and tell you a varying degree of risk. So relatives of a person with type 1 siblings, we can define risk at 60 or 80% in the next 5 years. You have a chance of getting it. But I can't tell you which SIB beyond, in specific terms. So we don't actually recommend screening and measuring things unless you're in a study. Now, if you're in a study, what the advantage is that people seem to pay a lot more attention to both being in the study, and they get diagnosed really early before anybody gets ketoacidosis or any bad things. People are more aware of it. But, I'd hate to, as a practitioner, I'd hate to have a blood sample on a sibling and tell you as the parent, the test is positive, but I don't know what you're supposed to do with the information except stop sleeping and be nervous. So unless I have a really good thing to do with that, that's going to change outcome, I probably don't want to have that information available yet. But we're working towards that because, we'd love to have a newborn screen for type 1. Because if we could identify really early, we could do all those good things to keep you in good health while we're waiting to get more sophisticated things.
I think Jack Rudis is working on that already. Okay, one more question.
Are the continuous glucose monitoring systems that are currently being utilized going to be of the quality where a closed-loop system will be possible?
Yeah, interestingly enough, you can do all the research on a closed-loop system with the current technology. The current technology suffers from it's not as user-friendly as you'd like it to be, especially for children. It's not miniaturized. It doesn't have all that other stuff, but it actually works. And the algorithm mathematician types are not slowed down at all by that stuff. So we need the miniaturizers and those people and to make it more user-friendly to come in place. So the technology is excellent if applied well. It's not user-friendly, so it's not often applied well. And people are not, anxiously signing up quite yet. But I think that will change dramatically because, pump usage is increasing worldwide, and the NICE report on pump usage that came out is helping that world. And the hooking some continuous assay onto the pump is helpful. And if I came tomorrow morning and told you that you don't have to wear this all the time, but I have for your child, just put it on at nighttime. It'll detect hypoglycemia, turn off the pump, do, whatever. You might like to use that, even though it's not perfectly user-friendly. So yeah, the technology is rate limiting, but it's good enough to do the job. Thank you. Thank you very much.